Hello, my name is Lindsay, and I'm going to be talking today about the Adult Partial Hospitalization Program, where I am doing my internship. So I'm just going to go ahead and share my screen. Okay, so like I said, we'll be talking today about the Adult Partial Hospitalization. So let's see here. So just to kind of go over a brief agenda talking about what we're going to be discussing today. So we'll talk a little bit about what is partial. So when I say partial or the program, I'm going to be referring to the Adult Partial Hospitalization Program today. It's a little bit of a mouthful, so just for the sake of time, I'll be calling it partial or the program. Then we'll talk a little bit about the focus intervention that I chose for this project and why that's kind of relevant to the program itself and me as a student and you all as students. Next, we're going to be talking about the target variable and the different measures that are used within and outside of the program to kind of measure that variable in mental health. Then we'll talk a little bit as far as brief literature review in regards to that variable, the measures, and then how that might have influenced, some of the feedback that I would have on the program as far as, um, you know, pro providing care for patients in this program. All right. So just to talk a little bit about referrals as far as the adult partial hospitalization program. Patients are referred from inpatient programs, CPAP, which is the Comprehensive Psychiatric Emergency Program, which is connected to the emergency department at the hospital, outpatient providers, so psychiatrists, therapists, even PCP would be considered. So someone's primary care doctor can also refer them. Typically, when a patient is referred from CPAP, inpatient, the ED, or even from like a mobile crisis referral, which is one of the mobile teams that works in the area to meet people where they're at for psychiatric evaluations or to help connect them with different resources. Those patients are typically seen immediately after discharge. So their appointment is likely to be set at partial before they've even left the hospital as part of their discharge meeting. So patients are generally referred to this 10-day program when they're experiencing acute symptoms that require a higher level of care than outpatient, but are not quite needing at this point or anymore needing the inpatient hospitalization. Patients present with anxiety, depression, suicidal ideation, complicated bereavement, post-traumatic stress, and recent suicide attempts. The program is focusing on a few targets in the short term of treatment, which are safety from harming themselves or others, returning to a safe baseline of their chronic mental health symptoms, ones that they might have, found manageable in the past, but they've gotten worse in a short period of time. So what we're really focusing on is those short-term symptoms that have been exacerbated. And we also help connect patients to a variety of resources, anywhere from outpatient psych providers, if they don't already have one, to food pantries, peer support, and anything else that we can kind of get them connected with in the community that'll better them or their mental health. The referrals are all managed by an intake coordinator. So our intake coordinator is a BSW. She's incredible. So she does all of the scheduling as far as the intakes, as well as kind of helping to connect, patients from CPAP or other outpatient or inpatient providers. If there are no-shows or cancellations, we do follow up with the patient to assess for acute safety concerns. So if a patient were to be referred from, say, CPAP, for suicidal ideation or an attempt or depression, psychosis, any number of reasons that they would be referred from CPAP. If they don't show up to a scheduled visit with the intake therapist will actually reach right out to the patient just to kind of assess safety. Do they want to reschedule? Are they going to be going back to the hospital? Do they have a safety plan? If in the event that they aren't able to contact that patient or collateral that was already contacted previously in their care, then they may call the mobile crisis team to kind of do a referral in the community. So like I said before, the mobile crisis team, they're a separate entity, but they do a lot of work with different parts of the University of Rochester. So they would be referred there, and they would call the patient and try to schedule a visit at the patient's home or somewhere in the community where they feel more comfortable. All right, so just a little bit more about the actual program itself. All right, so the program itself is about 10 business days. Patients are required to maintain a safety plan throughout the program. So they may be endorsing passive suicidal ideation or even active suicidal ideation. So a lot of the time, what they're going to do is they're going to have a safety plan that also is going to include some of their collateral support. So it could be a spouse, it could be a family member, it could be a friend, sometimes it's even a neighbor. So someone that is aware of the safety plan and someone that is aware of the risk. So sometimes what they'll do is they'll help by removing sharps from the home, managing medications, stuff like that. So it's very common just to make sure that the patient, while they're there, that if their mental health decompensates for any reason or gets worse, that they do have that safety plan in place. That safety plan is also going to include contacts for the mobile crisis team, CPOP, 911, 988, all of those resources. So the program itself is about 90% group therapy. So not groups in the sense of like sharing with one another, traumatic details. Groups more of learning about different coping skills, mechanisms, things that they can use in their lives to help improve in how they're feeling. While in care, Partial provides medication and therapy to patients because they won't be seeing their regular site providers until after discharge. Registered nurses work with the patient at the intake to address any ongoing or acute health symptoms that need attention, and they assess physical health or accessibility needs while they're in the program. So, such as assistive technology or devices. So, if someone needs a walker, if they need a interpreter, so these are all different things that the nursing team will work with them on. All right. So like I mentioned previously, Partial is about 90% groups. So my focus intervention is cognitive behavioral therapy groups. This setup allows for socialization, mutual aid, combined therapeutic exercises, practicing of skills, and accountability that all make Partial such a unique program. Groups don't work within the lens of one specific intervention, but the groups that I joined were more practicing cognitive behavioral skills in nature. As for my interview with the supervisor who is the social work clinical director, groups pull elements of cognitive behavioral, dialectical behavioral, and acceptance and commitment therapies. The program's group curricula have been adapted and over the years by different clinicians and leadership with the intention to improve, patients' acute symptoms and self-reporting on the PHQ-9 and the GAD-7, something that we will get into a little bit later. In groups, patients are practicing mindfulness, they challenge cognitive distortions, learn about and implement skills of self-care, they recognize adverse relationship behaviors like codependency, learn about boundary setting, practice coping, manage substance use, and they have the intention of lessening or even ceasing substance use while in the program. Patients commit to and practice making changes in their lives, and they are expected to identify coping skills that they are using throughout the program when they're checking in with the individual therapist and with the nurses. All right, so now to kind of just get into our target variable. I felt that it was only fitting that I chose a variable that represented the work that we do every day at Partial, which is stabilizing acute symptoms of depression. Upon intake, the patient identifies a recent period, typically 2 to 4 weeks, of worsening symptoms that have not gotten better despite working with a therapist, a psychiatrist, or their PCP, or using skills that they have learned previously while in treatment. The intake is a face-to-face assessment where we learn more about the patient, the presenting problem, what are their current supports, and what are their goals for treatment. Patients are expected to fill out the patient health questionnaire or the PHQ-9 in the waiting room, which is then entered into the flow sheets into their medical record, which is embedded into the intake assessment. A lot of patients come to partial with an outpatient provider or are referred as a step down from a higher level of care, like inpatient hospitalization or the emergency department. Something to consider in assessing acuity is the recent hospitalization, resistance to standard treatments, for example, depression getting worse after CBT or SSRIs, an outpatient or therapist or psychiatrist referring the patient for more support than they're able to offer at this time, and patients who have also come to the program before. Patients are encouraged upon discharge to return to partial at any time for an additional intake because it is an episodes of care model and people learn new things with every stay. All right, so as mentioned before, the standard measurement of depression symptoms that we use at partial is the PHQ-9. The PHQ-9 is not only used at the partial intake, but it's also used again as a comparative measure at discharge. But it's also used systems-wide in the University of Rochester in all kinds of outpatient settings, most commonly in primary care. In reviewing literature on the assessment tool, the PHQ-9 is used so commonly for a reason. It's standardized, it's easy, and it's proven time and again reliable and valid. The 9-question assessment can be performed by the patient or the provider to assess depression symptoms as demonstrated by the DSM. The top 2 symptoms that qualify patients are a loss of pleasure and depressed mood, which are very core to this assessment. Okay, so the literature also reviewed the Hamilton Depression Rating Scale, or the HAM-D17, as another useful tool for depression symptom management. However, it's not as commonly used in healthcare settings and is not used in the partial hospital. The main points are that the HAM-D17 is adaptable. It focuses on a wide range of depression symptoms and is not as easily influenced by the administrator. One of the things that Kennedy, one of the researchers, speculated is that in the PHQ-9, when the assessor or the administrator is giving it, he speculates that it makes more room for error or influence on the result in comparison with the HAM-D17. All right, so just to get a little bit more into these measures. So validity and reliability of the PHQ-9. When evaluating the validity of the PHQ-9, Kroenke et al. Found that the reliability and test retestability was excellent in their study of 6,000 primary care patients. Face validity for the PHQ-9 is excellent, as the 9 questions are explicitly relevant to the written criteria for depression. The assessment does not have questions on any other factors that may contribute to depression diagnosis, including differentials. In other words, at face value, the PHQ-9 hits all of the relevant points. When it comes to content validity, not only are there criterion assessed, but duration of symptoms, which helps the administrator to assess severity and differentiate between normal sadness or periods of being down and depression. Like, what are those differences and how does that feel different for the patient? Kroenke et al. Evaluated construct validity in relation to the patient's functional status and healthcare utilization in the primary care setting. Criterion validity is excellent, as the 9 criteria are the content of the assessment. So when we're talking about acute depression symptoms, the validity and reliability of the HAM-D17, I think was very imminent, and I think that important to go over. So the C. Mueller et al. Published an in-depth analysis of different measurement tools for depression, which heavily focused on validity and reliability. As far as face validity goes, authors demonstrated the sheer history of this measurement tool, the HAM-D17, and how it was developed for patients that were actually in inpatient hospitalization for depression. The measurement tool itself has proved time and time again internal consistency, and C. Mueller et al. Really praised the multidimensional validity of the HAM-D17. Beyond face validity, the Hamilton, or the HAM-D17, assesses symptoms of anxiety and vegetative symptoms, making the overall construct valid in diagnosing illness and providing valuable information for treatment planning. Kroenke, who we talked about on the last slide, stated that the HAM-D17 has become the criterion standard for measurement in clinical trials. This, to me, speaks very heavily to the reliability of the tool. The construction of the HAM-D17 also allows for less suggestibility and is generally not given as a self-assessment. So clinical judgment is often used by mental health professionals when using this. All right, so just to kind of discuss a little bit as far as feedback and recommendations for the program. All right, so if I were to provide feedback to Partial, I may encourage utilizing the PHQ-9 as a control variable to maintain consistency between different providers. So Partial, outpatient therapists, outpatient psychiatrists, and primary care, but use the HAM-D17 internally for symptom progression. So although it takes more time to administer, it may produce more reliable results for the short-term acute nature of the program. So the HAM-D17 could be something that could be used at the intake evaluation for a really good idea of what is going on, what do these symptoms look like, how is the patient reporting these symptoms, and then comparing that at their discharge. How is the patient feeling now? What do they feel was helpful? And then maybe even discussing that with them of like, look at this progress. This is, fantastic, or whatever word that we want to use to show them how, the success rate that they had in this program. An intervention recommendation includes following up with patients at 3, 6, or 12-month intervals to evaluate symptoms using either the PHQ-9 or the HAM-D17. So like I said before, the HAM-D17 does take a little bit more time. As far as following up with patients, it may be more efficient to use the PHQ-9, but I do think that there is a good reason to follow up with patients at 3, 6, and 12-month intervals, especially with having some patients that do return to care. If possible, we could call patients to assess the symptoms. So a staff member from Partial could give patients a call, do the PHQ-9 over the phone, or if necessary, we could always refer to the PHQ-9 that is administered at the patient's primary care office through an electronic chart review. So like I mentioned earlier in the presentation, a lot of primary care providers within the University of Rochester are using the PHQ-9 to assess for symptoms. That's how the conversation can get started. That's how a lot of referrals get started. And that's something that they are assessing at most of their primary care appointments. As we know, most of those are every 6 months or even sooner if people do have specific needs that they have from their primary care doctor. So this is definitely something that I think that we could do and that we would have access to because we have the same electronic medical system, or excuse me, the same electronic medical record as a lot of the providers within the University of Rochester. There's also the opportunity, I believe, to select patients for a comprehensive follow-up study that includes reevaluating them and obtaining collateral support. So what this would look like to me is reaching out to patients, asking them to come in for an intake, and then talking to their outpatient provider and collateral. So this is something that we do initially anyway to get a big picture or a good picture of the symptoms that they're going through, the progression of the illness. And I believe that this is something that we could absolutely do as a study. Due to resources, and maybe something that could be a good project for interns to do in the future. I would not be opposed to doing it myself, but I do think that it would give us a lot of insight as far as how long the success of Partial stays with people. How long does this go into treatment afterwards? How long does this help people afterwards? I hypothesize that patients would continue to do well in the 3, 6, and 12 months after a program if they felt that they were successful in their care. So what that looks like for me, if they felt that they were successful, so if they were reporting less suicidal ideation, less depression symptoms, less feelings of worthlessness or hopelessness, or even the almost opposite of that, like feeling happy, feeling excited, feeling like they had a lot to look forward to. And then connecting them with different psychosocial resources, I think also plays a lot into what they feel that the success with the program is. Our BSWs at the program will connect people with all kinds of resources, whether it's housing, groceries, care management, whether it's different like programs or clubs kind of in the area for things that the patients are interested in. So it's a very, very personalized program. A study could be done also of patients that have attended the program more than one time in the past 2 or 3 years. This would help leadership to understand any necessary changes to the program or what risk factors there are for patients that do have a higher return rate. We could look at the measurement tool at intake and at discharge. So whether that was the PHQ-9 or whether that was the HAM-D17, if we do implement that, excuse me, if there's a common thread between diagnoses, so if these are patients with recurrent depression, with psychotic disorders, if these are patients that have anxiety disorders, what did their progress look like when they were here? What were their goals when they were here? What were the psychosocial factors that were evident at that time? Did they have any barriers to care? What was their attendance like? I think that a lot of this information could be very insightful as far as what we could be offering in the program. Thank you so much for listening. I really appreciate it. And if you have any questions, you're more than welcome to comment down below in the discussion post. I'm really happy to talk about it, and I'm very grateful to be at this internship.